We're really excited to have this conversation about the future of the primary care workforce. And we have an outstanding panel today moderated by a national expert on these particular issues. And I'm going to turn it over now to Dr. Margot Savoy.
Thank you so much, Sean. Good afternoon, everyone. So I am really excited because we're going to talk about a topic that is near and dear to my heart. We're talking about what happens if primary care disappears, which is really a focused conversation about workforce in primary care. My name is Margot Savoy. I'm a family physician. My day job is as Senior Vice President of Education, Inclusiveness, and Physician Wellbeing for the American Academy of Family Physicians. It is my honor and my pleasure to moderate this session today. Over the next 75 minutes or so, we're going to look to have a conversation about the impact of the diminishing primary care workforce and what actions primary care organizations are taking to make this trend go away. So we're going to be talking a lot about the things that we are doing today and also where we want to go in the future. To get this started, what we wanted was to level set on what is really happening out in the workforce, and we couldn't think of a better person to come and deliver some opening comments and remarks for us. Dr. Yalda Jabbarpour, who is the director of the Robert Graham Center, is going to get us started with a keynote presentation. I'm going to ask you to join me in welcoming her to the stage.
Thank you, Margot. It's a pleasure to be here with you guys, and as Margot said, I'm going to take just a few minutes to set the stage for the wonderful discussion that's about to come about what happens if the primary care workforce disappears. And sadly, we're at a pretty critical state. We're not super far away from that reality of what will happen as the primary care workforce diminishes and disappears. So I'm going to spend some time talking to you about the data that we collected for our recent scorecard on primary care. This is all published online on the Milbank Memorial Fund website, as well as the Robert Graham Center website. It was funded by Milbank and the Physicians Foundation. I can't go over every piece of data in that report. I really encourage you all to take a look. So it's the second year that we've published this report. And in this second year, we really wanted to focus on access. And why is that? Well, these headlines say something about that, right? I'm sure this is no surprise to any of you who work in primary care, practice primary care, who have tried to seek out a primary care appointment over the last couple years. I know my patients tell me it takes about 3 to 6 months to get in with me. That's my already established patients. When they have new friends moving to the area, they tell me it takes those new friends about a year to find a primary care physician. We are not in a rural area. We are in Washington, D.C., and that is what's happening. But it's not only anecdotal data. We looked at the Medical Expenditure Panel survey to examine the proportion of the U.S. population that does not have access to a usual source of care or primary care. And what we found was pretty startling. Over the last decade, this number has gotten worse. In the most recent data, over a quarter of US adults report that they don't have a usual source of care, and 13% of US children don't have a usual source of care. This is pretty alarming considering that primary care is essential to manage chronic disease, to manage mental health and behavioral health issues, and to provide preventive services like vaccinations. So why is this happening? And this is the title of our report. Why can no one see you now? There's a lot of reasons. I think we turn to these 5, which is that the primary care workforce is not growing fast enough to meet population needs. The number of trainees who enter and stay on the professional pathway to primary care is too low, and too few really have community-based training, and I'll tell you why that's important. The United States continues to underinvest in primary care. Technology really has become an added burden to primary care. It's not really expanding access. And finally, primary care research to really identify, implement, and track care delivery and payment models that are working is lacking. So let's start with workforce. A decade ago, people in this room and others were sounding alarm bells that we do not have enough primary care physicians to meet population demands. A decade later, with a growing and aging US population with more chronic disease, more mental health needs, that number has not grown, it's actually shrinking. When we add other members of the primary care team to this equation, specifically nurse practitioners and PAs, at first glance, this actually looks much more favorable. We are seeing growth in the primary care workforce. But is it sufficient and is it sustainable? The answer is likely not, and I'll give you 2 reasons why. It's not sufficient because even at our maximum where we are today, we still do not have anywhere near the primary care clinician per capita ratio that other developed countries have. For example, I have Canada up there. It's literally off our chart, right? They have about 120 to 130 family physicians per 100,000 population as compared to the US. So it's not sufficient. Is it sustainable? The answer is likely not, although there has been a rapid growth in the nurse practitioner and PA workforce. The same pressures that are driving physician trainees out of primary care and into subspecialty care are also driving nurse practitioners and PAs out. In fact, in our appendix, in the scorecard, we show that only about 30% of nurse practitioners are currently working in primary care and less PAs. So it's probably not sustainable. But there is a ray of hope when we look at the workforce, and that has to do with how we are distributed. I know there are maldistribution issues when we're talking about rural areas, but when we look at areas of social disadvantage as measured by the Social Deprivation Index, which is essentially a small area level index that looks at factors that impact health but are outside of healthcare, things like poverty level, housing, transportation, we can see that there are more primary care clinicians in areas of higher social disadvantage, as represented by that orange line, than areas of lower social disadvantage, as represented by that gray line. We're not sure why this is happening, but we have 2 hypotheses. One is the community health center effect. Community health centers, which tend to employ a large whose employees are primary care clinicians mostly, are located in these areas of social disadvantage. We also think this speaks to the social mission of primary care clinicians, where they really do tend to distribute themselves in areas of social disadvantage. Now, why don't we have a robust enough workforce? Part of it has to do with training. This data looks at physician training. You can clearly see the blue line, which is primary care physician residents per capita, and the orange line, which is all other specialties. Both are growing, which is great. We have more trainees per capita than we used to. But the subspecialty training is growing much faster than the primary care specialty training, as can be evidenced by that growing gap between the blue and orange lines. And added to this, what we found in our data and is reported in the scorecard is that not enough physicians, including not enough primary care physicians, are really training in the community. They're training in large academic medical centers and hospitals. And why does that matter? It matters because we know how and where you train really impacts how and where you end up working in the future. And nothing speaks to that statement better than this graph, where we look at the percentage of US trainees that end up working in primary care 3 to 5 years after graduation. That blue line shows the percentage when we include primary care hospitalists. That orange line shows our community-based primary care physicians only. And only about 12 to 15% of all US trainees end up practicing community-based primary care, despite the fact that most of the US population receives their care in the community, not in hospital settings. So I've told you that we don't have a robust enough workforce, and part of that reason is that we are not training the right way in the right settings. But all of this, I think, comes down to investment. We are simply not investing enough in primary care practices. And why does that matter? When you're not investing enough in primary care practices, you have teams that are too overburdened, too stretched out, cannot provide all the services that are needed for their patients. You're not investing in infrastructure that could expand access. And then you have trainees going into these settings. They're not going to pick primary care when they see that. So what we looked at was the proportion of total healthcare spending in the United States that's been invested into primary care over the last decade. It's divided by payer here. Each line represents a different payer. Yellow is Medicare and orange is commercial. So yes, Medicare is investing less in primary care than commercial, but the overall message here is that the investment is low and it has not grown over the last decade. If anything, for some payers, it's falling. And what about digital health? Can it deliver on its promise to expand access by allowing us to do asynchronous care of our patients, allowing us to do better population health management? The answer is, in its current form, probably not. This data, which was taken from the American Board of Family Medicine, shows that physicians just are not satisfied with their EHR, and that they feel that their EHR is not integrated enough to help them deliver the care that they need to deliver. And finally, are we investing in researching care delivery and payment models that might help support a growing primary care workforce or better access? The answer is no. In fact, when you look at all federal funding for research, including CDC funding, FDA funding, NIH funding, and ARC funding, only 0.3%, let me repeat that, 0.3% is being spent on studying primary care. So we are spending less than 1% of all federal research dollars examining and researching the backbone of our entire healthcare system. So I'll take you back to the title. Why can't anyone see you now? I hope I've shown you that no one can see you now because we have an insufficient workforce. We have not enough trainees choosing primary care. We have a lack of investment to support teams, digital healthcare that adds to workload instead of supporting us, and no support to study models of care delivery and payment solutions that may help in the future. Thank you very much.
Thank you so much, Yalda. You certainly gave us a lot to think about. Some of it gets me a little excited because it gives us places and opportunities to lean into, but most of it was kind of depressing. We're going to lean into a really, really fantastic panel of discussants. What we want to do is give everybody a chance to sort of respond and react to what Yalda's talked about, but also give them a chance to introduce themselves so you know a little bit more about them and their organizations. Why don't we start with, from the American College of Physicians, Bill Fox.
Yes, thank you so much, and it's great to be with everyone today. My name is Bill Fox. I am a primary care internal medicine physician in a small, still independent 3-physician practice located in Charlottesville, Virginia. So that's something that's not done much anymore, but we've been in business for 21 years, and we generally practice through traditional insurance models, though we do participate in an advanced alternative payment model through an accountable care organization, the Medicare Shared Savings Program. Prior to that, I worked in a federally qualified health center as part of my work in the National Health Service Corps in rural Virginia. But currently, I do that as my day job, but I am also honored to be the chair of the American College of Physicians this year. The American College of Physicians represents internal medicine physicians, and we are actually the largest medical specialty organization in the country. And actually, depending on what statistics you look at, internal medicine physicians make up either the highest share or one of the highest shares of the primary care workforce in the country. So I have an opportunity to kind of see what's happening with primary care from like a higher policy perspective, but also from a boots on the ground perspective. Now, we think at American College of Physicians that primary care is the backbone of a healthy infrastructure in the United States. But as we just saw, years of underinvestment coupled with significant administrative burden on our physicians, has led to significant attrition of the workforce. Just at the time when we need that workforce more than any other time, we are at the point where the silver tsunami is upon us. More people are retiring this year and turning 65 than at any other time in history. And so as we just saw, the proportion of people without a usual source of care is actually increasing. In my own practice, when people call for a visit, we're seeing access problems like we never have before. So when someone calls as an initial patient, if we can see them at all, it may be a year. And we see patients crying on the phone. And when I try to refer to specialists, especially what we call cognitive specialists, the waits are easily 3 to 6 months. But I think a lot of this is a self-inflicted wound, and I think there are solutions out there if we have the will to do it, and hopefully we'll get to that within the conversation. So again, it's great to be with you all, and thank you so much.
Thank you, Bill. Next up, we have from the American Academy of Pediatrics, Cheryl Pinto.
Hi, good afternoon, everyone. I'm Cheryl De Pinto from the American Academy of Pediatrics, and I'm the Senior Vice President for Primary Care and Subspecialty Pediatrics. So in my role, I have the opportunity to not only look at primary care-related issues, but also looking at issues as it relates to team-based care and the way in which in communities, subspecialists and primary care providers are able to work together in a seamless way. So at the AAP, we really believe that all children deserve to have access to a medical home where they're able to receive continuity of care, high-quality services that are delivered in an equitable way that does not allow for any type of bias or discrimination. And in that way, as a result of that, some of the things that we have been working on is looking at issues of equity, payment reform, mental health services, as well as trying to leverage technology to support our primary care providers. So as we look at issues related to equity, one of the things that we are constantly looking at is the changes in the demographics of the pediatric population. And what we're seeing is that pediatric children and communities are becoming more and more diverse. However, we're not seeing much change in the diversity of pediatric providers. And so as we are looking at workforce issues, we're looking at things like pathways to pediatrics, digging deep into underrepresented in medicine populations, trying to get a situation in communities where families and children can access care with a provider that looks like them. I think there's a lot of data that suggests that concurrence with the ethnicity and race of your provider really does contribute to better outcomes. When it comes to payment issues, this is one of the things that is really, really challenging for pediatrics. We have talked a lot or heard a lot today about payment issues, but for pediatrics, it's even more dire. What we know is that Medicaid is the primary funder for clinical services for children, with more than 50% of children on Medicaid. When you combine that with the fact that Medicaid pays only about 2/3 of what Medicare pays, and that is only half of what a commercial payer pays, the pediatric financial sustainability for small pediatric practices is really, really dwindling. And we're finding that more pediatricians are employed by larger health systems as opposed to being employed in those smaller independent practices. And that trend has continued significantly. So as we think about how we can address the payment issues, Medicaid is a very important lever that we need to pull. And so at the AAP, we're working very hard at advocating for reforms within Medicaid. We have a recent policy statement that calls for robust changes at the federal level as well as at the state level for the Medicaid program. And now the unfortunate part of that also is that despite the fact that pediatricians are among the lowest paid clinical physicians, we're being asked to do more and more in the clinical space. And that's no more evident than the fact that mental health conditions in children are rising dramatically. So much so that during the pandemic in 2021, the AAP joined the American College of Child and Adolescent Psychiatry and the Children's Hospital Association to declare a mental health crisis among children. And so in order to address this, what we're needing to do is to better train pediatricians to be able to provide mental health services within clinical practices. But along with doing that, we also have to think about how does that affect the overall way in which pediatricians are trained. And then in addition to that, how are we going to innovate payment models to be able to account for the provision of mental health services in the primary care setting? And then lastly, I'll just mention a couple things related to leveraging technology. What we found amongst our AAP members is that the use of telehealth during the pandemic skyrocketed. And what we're also seeing is that many of our members continue to use telehealth. So in addition to trying to address mental health needs, address administrative burdens, trying to learn how to provide quality, appropriate telehealth-based services is another thing that we're supporting our primary care providers to do. And we're looking at things such as providing webinars and other types of training programs to help to enhance people's comfort with utilizing telehealth. The good thing is that when we look to our pediatric residents, we're finding that more and more of them are learning in their residency program how to use telehealth, and they're quite satisfied with the training that they're receiving in terms of learning how to appropriately use telehealth. But when you think about people who have been in practice for a long time, there is a huge shift in the way in which pediatricians have had to learn how to incorporate telehealth into their practices. And we do think that telehealth is a great way to enhance the medical home and improve access to quality primary care.
Thank you so much. Next up, we have from the American Association of Nurse Practitioners, Joyce Knestrick.
Hi, thank you so much for having me. As she said, my name is Joyce Knestrick, and I'm a past president of the American Association of Nurse Practitioners and a family nurse practitioner. I feel like I have to say this all the time, but nurse practitioners assess, treat, diagnose, and manage patients. We have prescriptive authority in all 50 states, and we see about 1 billion patient visits per year. According to our data, 70% of nurse practitioners are in primary care settings, and according to MedPAC, about a third of primary care is offered by advanced practice nurses and PAs. So I thought about this panel, and I thought about what would happen if primary care did not exist. I just couldn't. It's not that I can't imagine it, because I grew up in poverty. We didn't have a family doctor. That's back when you had hospitalization. Primary care services were not covered, and people basically went without basic healthcare services. I think people forget, that happened. So I think I can't imagine how far we've come to go backward, not to have a good primary care system that can help build those relationships. We heard about that in the prior panel about building trust and relationships in primary care, but also managing people with chronic illnesses, teaching them disease prevention and health promotion, all of those areas that come into play in primary care that are very important. In my 30 plus years as a nurse practitioner, and I think when I first started, our workforce was about 25,000, and so we could see that we've 385,000 now as a significant gain in our advanced practice workforce for nurses. But I think about the patients that I've counseled, that I've diagnosed with critical illnesses, with chronic diseases, working to manage patients with complex problems. When you work in a population that I work that's primarily uninsured, underinsured Medicare, Medicaid patients. We are spending a lot of times looking at social determinants of health, how it's impacting their care, how do we get adequate services, how do we get them a ride to and from when they do get an appointment, all of those things that all of us in primary care, I think, are experiencing, as well as the previous speaker spoke about the mental health issues that we're seeing. And of course, the population in IC, besides mental health, many social and social determinants of health issues. So I really think that building a robust primary care that is funded and is paid for is really important, that we need to use innovation and we need to have access to the patient's provider of choice to provide that adequate patient and person-focused care.
Thank you so much. Next up, from the American Association of Physician Associates, we welcome Lisa Gables.
Thank you so much for having me here. I'm Lisa Gables, the CEO of the American Academy of Physician Associates. And much like our previous speaker, our population is on the rise, which is a great thing. I started with AAPA about 12 years ago. We had 87,000 PAs. Today we have 178,000. So in about 12 years, we've seen that kind of exponential growth, and there's no slowing down. PAs are medically trained specialists who also work in primary care, but we have seen a switch. When I started, we had 25 to 35%, depending on the market, in primary care. Today, we're down to about 22%, which is not a good thing. We want more PAs in primary care. So it's been our focus at the Academy to really try to ensure that we're highlighting the issues of payment reform, of looking at ways to train PAs to go to rural areas where there are really critically underserved populations that don't see any healthcare. Just yesterday, I was in Texas for our annual conference, and there are 26 counties in the state of Texas with no healthcare whatsoever, none. So we need people. We need more people, and this notion of primary care dying away is scary and should be scary to all of us. I do see some hope on the horizon, though, because we also heard at our conference a very interesting futuristic speaker, Dr. Daniel Kraft, who was telling us all about the new technology coming online. And while I don't think it's here exactly right now, as our first panelist talked about, I think it's coming. And I do think there are ways to leverage all of our clinicians to use digital health to our benefit to try to get at those underserved areas as we move forward. So I'm very proud to represent this profession. We are a young profession. The average age of a PA is 35 years old. So we don't have quite the same issues with people leaving the profession. However, provider burnout is real. So it's something also that we really strongly work toward, the mental health of our providers. It's very important to us, along with the mental health of the patients that they serve. But I'm super excited to be here today and have this conversation with everyone.
Thank you so much. And from the National Association of Community Health Centers, we welcome Michael Taylor.
Good day, everyone. What a pleasure to be here. I am going to talk about two hats that I wear because I think they're both relevant to this conversation. As indicated, I am the president-elect of the National Association of Community Health Centers. For those of you who might not be familiar with community health centers, there are approximately a little less than 1,500 of us spread across the country, largely in underserved areas. Both urban and rural. So you saw the chart reflected earlier showing a concentration of primary care capacity in some settings. And it's probably true that those are because of community health centers. That's why that capacity and improved access exist in those communities. Now, I will say that community health centers today are more significant than people might understand. We now serve 31.5 million people in this country collectively. That's 1 in 11 Americans. So it is indeed the largest primary care delivery system in the country. I'm so glad that Cheryl talked about Medicaid because it's a bugaboo of mine. Because when you talk about underinvestment, one of those is in adequate payment rates that allow us to sustain a primary care delivery system. So I'm not going to go off on that tangent right now, but I want to recognize that, because underinvestment means a lot of things. The second hat that I wear is that I am the CEO of the Cornell Scott Hill Health Center, which is based in New Haven, Connecticut. And we are along the spectrum of 1,500 community health centers, and are fairly somewhat involved. We care for approaching 60,000 patients per year. We are as much a provider of primary medical services as we are a provider of behavioral health services. So we have a staff of over 700 people. Half of those are devoted to the provision of behavioral health services, both substance use treatment and mental health. We also happen to be the ambulatory teaching arm of Yale New Haven Hospital and Yale Medical School. So we actually have absorbed and we manage their internal medicine and OB-GYN clinics. So we are, in that regard, a teaching health center. So a lot of hats here, and all are relevant to primary care. I really want to explore this notion of underinvestment in primary care because I think it's important. It impacts the number of graduates who are available to us. It impacts our reimbursement levels, determine the extent to which we can retain the most qualified people. The supply is too short. The number of people who are part of that inventory are increasingly costly. And when reimbursement doesn't keep track with market forces around costs, we end up with a short supply of providers and less access. So I am very interested in talking about ways to improve investments in primary care that also allow for things like the growth of teaching health centers. Of the 1,500 health centers, and you heard earlier as well, that when students, residents are given the opportunity to practice in community-based locations, it's more likely that they're going to continue their careers in those settings. But there are fewer than 100 teaching health centers in the country. Again, inadequate investment enables that. So I'd love to see a greater focus on the development and expansion of community health centers. Because what exists right now, other than those fewer than 100, is a series of cobbled together contractual relationships that might be state funded for a year or two, and then there's no guarantee. A number of relationships that are with one college or another that don't have any subsidy that enables an organization like mine to embrace teaching, because teaching comes at the cost of reimbursement that sustains our ecosystem, and that's a problem. So.
Well, thank you so much. So when I had the chance to reflect on Yalda's presentation, I just really was struck by the fact that there really are these opportunities that are facing us, but they're sort of daunting challenges. I mean, they're not insignificant things that she's talking about. So there's a loss of incoming workforce, which sounds like a medical school residency training potential issue. And then there's this loss of the workforce on the other side, which sounded like a combination of burnout and retirement, either of which are problematic. If you don't have people coming in and you've got people leaving, you kind of get left. And I know that when we think about the communities, it was really exciting to hear that community health centers offered maybe the one bright spot or the brightest spot, I think, in what she was describing, because it sounded like a model where you could really bring together an opportunity to address that incoming group. So fixing a way to have a teaching health center space where you could have someone learn in the community, learn around their community, but also a place where people might be able to deliver care in the way that they enjoy and taking care of populations that they care about. Can you talk a little bit more about how y'all managed to do that in a way that seems to be pretty resource expensive, and yet you somehow figure out how to make it work? So how does that work?
Ouch. Resources are few. Community health centers have been around for more than 55 years now, have always, despite their growth, have always been underfunded. And so we have become very resilient and very creative. And we know how to stretch a dollar and become efficient, but still meet the needs of the communities that we were founded to serve. I liken it to pulling a rubber band over an extended period of time, and I fear we're coming to the point now where the rubber band is about to break. Because unless a significant additional investment is made, and that investment is sufficient, that investment is reliable, meaning more than 1 year at a time, because you can't sustain a business when your funding only comes to you 1 year at a time. You can't sustain a training program when you're only funded 1 year at a time. I fear that rubber band will break if something doesn't give around sustainable funding.
Thank you. I very much agree. Any other thoughts?
I also practice in a community health center, and I would say I'm very thankful for our executive director who spends a lot of time and her team constantly raising money and looking for new opportunities. It really takes all of us, I think, even the providers, to pitch in and work to sustain that community health center. And it really takes the community, and that's why you have to be really a part of the community, because you need those advocates within the community to help you sustain. And I think they get tired of working so hard too.
Very fair. I mean, I think one of the things that sometimes people maybe under recognize is that you don't have to be one or the other. In most parts of primary care, it's one of the reasons I love family medicine so much. You can just do all the things. And I know that I've spent my whole career working in larger health systems or academic health systems, and we always had affiliations with community health centers. Mm-hmm. You didn't have to choose, did you want to be academic or did you want to be community? You got to be academic in the community. And I think sometimes we lose that opportunity to remind our learners that you don't necessarily have to pick one path or another. Your path could be one that includes all of these things. And I think you hit on something about the teaching health center. So Yalda very clearly showed us that we don't necessarily invest in primary care. Often we think about that on the practice side. So thinking about how are we creating payment models and things like this. But you alluded to something around the teaching health centers and about needing to be funded for more than a year to be able to maintain your program. I think that's true for many of us when we think about residency training and people really investing in the places where you're training people to be that next generation of primary care. So thank you for bringing that up.
Could I just add another point? Because I think you certainly alluded to it, and I've heard it again and again and again from our providers. Combining being able to practice in an academic setting and in a teaching setting, and also being over the course of your career to also have a community-based practice really is a wonderful career experience for someone, because it gives them a variety and it gives them a sense of home and a team to learn from and ways to experiment and question and improve the delivery of care. That's the best option, I think.
I completely agree.
Yeah.
Primary care, the chef's kiss of medicine. So if we think about something that really came up as all of you were talking about sort of what you took away from her presentation and the work that you're doing, I heard technology come up a lot. I heard it come up in different ways. And so I heard things like telemedicine. In earlier panels, I've heard people talk about things like how we're pulling data and using data in different ways. So just lots of ways that technology can show up. Cheryl, you specifically spoke about using technology to extend care access, so making it possible for people who can't necessarily access, for example, behavioral health, to be able to actually have access to mental health services through technology. Can you talk more about how that would help us with some of our workforce challenges?
Sure. So again, we heard in some of the presentations earlier about the need to have volume of patients to be able to meet the needs of the community. And so when we think about not only what can make things easier within a practice, but also ways to design the way in which services are delivered to meet the families where they most need. We know that families really liked being able to access telehealth during the pandemic. We know that families who in some situations may have very restricted time to be able to, in our case, bring their children to the pediatrician at the frequency that they're needed. Being able to extend the practice of pediatrics into the community by making those services available is something that really helps to revive pediatricians in their feeling of doing a great service in the community. But in addition, it can extend things geographically, so we're not forced to having to always have that large concentration of providers within a particular geography, that you can extend access through great distances, especially with subspecialty care. And I know that we're talking about primary care here, but being able to have a primary care provider say, there's a subspecialist who will see you through telehealth is also something that is very helpful to pediatricians. I know one of the things that we're doing, leveraging technology in terms of being able to access consistent and quality care, is that we are working on digitalizing some of the resources that we provide to primary care pediatricians. So some of you may have heard of Bright Futures, which is the program by which it sets forth the guidelines and the schedule by which children see their primary care provider. And knowing that children see a primary care provider on great frequency in the first 10 years of their life, trying to make things easier for the clinicians to be able to not only provide the care that they know is necessary, but also to be able to know that it's quality evidence-based care. And so being able to have tools to be able to know what they're supposed to do within each setting in a very accessible way is one of the things that we're innovating the Bright Futures program by going to a digital-first platform by which those resources and tools are more available, not only from a resource perspective, but also within the clinical setting, within the care delivery room, that they can access those resources very quickly in a searchable manner to more effectively meet the needs of their patients who are there. So that also extends access, it builds efficiency, and also helps to improve the well-being and the joy and satisfaction of providing care.
I think that makes so much sense. Earlier they were talking about reducing the cognitive load so that you could just have time to think and actually be with the patient in the room, and digitizing resources and making them more easily accessible to you at the point of care is a really great way to do that. So what a great example. Thank you. Anyone else with thoughts?
I think technology holds such enormous promise, but as we saw from Yalda's presentation, there is a double-edged sword here. There's still an enormous amount of frustration with the use of the technology that we have, and we know that for every hour of patient-facing time, physicians and other clinicians spend an additional 2 hours on the computer doing administrative work. But when I think about the reach that technology can give us in terms of how do we reach our patients, and through telemedicine and through telephone, it occurs to me that we have gotten, since the pandemic, the ability to do what we've been asking payers and Medicare to do for decades, which is to pay for care through the use of telephone and audio-video technology. The telephone was invented 150 years ago, and just several years ago, Medicare said, hey, I think we can use this as a tool to deliver care to patients. It's crazy that it has taken so long. We also have to think about all the potential benefits of artificial intelligence. And I look at artificial intelligence in multiple different ways, but one of the most important ways right now is how do we leverage it to get rid of all the busy administrative tasks that we do. And there are many companies that are already popping up to be able to help us handle that work. And so I think that aspect of technology is very promising.
So in a rural area, sometimes access to the technology is difficult for the patients. So I think we have to know that we can't assume that everybody has access. So most of my patients have a phone from Walmart with limited data, limited calling, limited text. So we have to be cognizant of how much time that we might expect them to use that device for, because they have to go put more money on it that they don't have. So there are still some access issues even within something that's supposed to help with access. So I think we need to understand that. And I think also I love about the community and the primary care model is that we really know the community and we know the patients and we know who's going to have those access issues and how can we help them gain access through whatever tools that we have available for us.
One just final point I would add about this, again, just coming off of listening to this very robust conversation, was really the cost of technology in the next 10 years is going to go down sufficiently so that people can afford it and can get it at Walmart or other places. So there is going to be a revolution, not only, of course, in the technology itself, but in the efficiency and the cost of and availability to more people. Every company that I've talked to, this is on one of their main things that they want to talk about is how do I get my product to the market that everyone can use it. So I think we're going to see in the next 10 years some significant change there.
I think those are really great points. I know that from the family medicine side, I spent a lot of time thinking about, how can I make life easier for those people that are already in practice? And so I definitely see where AI being able to take out that bottom of the burden really would bring back the joy in medicine for so many people because they could just go home and go to bed for once instead of having to stay up and work all night on charts. And so there's this beauty on that side. But I also see the other side where students and residents get really excited because you look like you're modern. So nobody wants to go into the specialty that's in the Stone Age. And so when all of a sudden your family medicine doc is leveraging the newest and the latest and the greatest technology in a way that also lets you demonstrate how you can take care of people in the way, and you're putting the people first and putting the community first. So you're marrying both that excitement of the technology with the joy of practicing medicine. It just seems like such a cool thing. I'm just thinking about it from that learner perspective. And so you're actually, again, really leaning into fixing this workforce challenge from both sides. So not one or the other, but really leaning in to both. I heard both Joyce, you and Lisa speak about how in your specialty areas, you're seeing sort of a rise in people's interest, but then also some maybe a little bit of fall off where people maybe are coming in with that wish to do primary care and then maybe drifting a little somewhere else. Can you talk a little bit about how you think you had the success in the first place and like maybe where you go from there?
So I think in our case, primary care is, PAs love community-based care. It's fascinating to see. When in the last 12 years, getting to talk to a lot of students, what they love about their profession is the ability to spend time with patients and to give back to the community. So we've, over the years, seen a little bit of fall off, and really it's for the same reason everyone else leaves primary care. The money isn't there, right? So payment reform is an absolute necessity to keep people in primary care and to attract new people. So payment reform and all the various things we've been talking about today is critical. But what I have seen happen is even those people who leave primary care and go into specialties as PAs, they still want to help in the community. So they volunteer. It's crazy. We have all kinds of programs to help them. If they're in a cardiothoracic surgical unit, they'll come back and come to the community to talk about how to eat healthy. Food is medicine and a healthy heart. So it's fascinating to see. And just this week, we did 2 projects in Texas in 2 different clinics and helping underserved populations. So it's just the volunteerism, the idea of community is something that PAs really thrive on. So I think that even if they're not working in primary care, there are still a lot of them who come back to the community to provide service. So payment reform's the key. Right?
And in nursing, we've always had a community-based models for our education. So it's been very important for us to continue to educate our advanced practice nurses in community models. But we want to make sure that our nurse practitioners are able to practice at the full scope of their licensure, which tends to sometimes be an issue for us in certain places. And so we have really good models like the Health Wagon, I'm sure everybody's seen in Wise County, Virginia. We have models of community involvement from various schools across the nation that are producing nurse practitioners who practice, in the community, and then they tend to stay in practice in primary care in this community. And that's what we try to strive for, but we have the same issues about reimbursement, staying in. If you find people who are really good, they're recruited by specialty practices, to go in, and the money looks good. And same thing, they might come back and volunteer, but then we've lost that primary care provider. But we want to make sure that we have opportunities for people to practice within their full scope.
So I think I'm hearing that money is a problem, because I've heard it like 3 different ways, right? So I'm hearing money is a problem because you're not investing in the practice itself, so you just can't get your work done because you can't get the tools, the resources, the technology, or just the human capital that you would need to take care of the patients in your community. I'm hearing money is a problem because people are getting attracted to other things because they're getting lured by money. So you spent a lot of money going to school and you want to be able to recoup on that investment. And so even people who have a love and a passion for primary care may be choosing to do something else because they're not.
They have to make a living.
They got to make a living. Yeah, student loans is a thing. That's a real thing. And so that I hear that money. I'm hearing that even the things that might make your life better cost money. And so you need to have the ability to do that side of it too. So it just seems like that's a theme. So if you're listening and you're wondering how you could help with the workforce, it sounds like money is a high answer. So I just keep hearing it come up in so many different ways.
And I'd like to really bring clarity to this conversation about payment reform, because in many instances when you talk to policymakers and payers, their perhaps unspoken definition of reform is, I'm going to give you the same dollar and I want more from you. Okay? It's not that I'm going to reshuffle the deck and primary care is going to be given a higher share of the premium. It's that I want more from you for what you're getting today or less. That's not reform. That's a pay cut.
I would add to that because, again, from a pediatric perspective, the money issue is really, really significant, just again, because pediatricians are among the lowest paid providers. But again, the idea of the passion for providing care needs to also be providing the incentive through money is one thing, but being able to retain by providing resources and supports, not just in the clinical space, but also in communities at large. Because again, when we think about healthcare outcomes, and we remember that clinical services only represents about 20% of the clinical outcomes. So the investments in the clinical primary care workforce are absolutely needed. But from a payment reform standpoint, if we really want to get better clinical outcomes for our patients, we need to think about how do we invest in better partnerships with clinicians of other agencies and service providers to address social determinants of health. Because those social determinants of health are also quite costly, and being able to figure out ways to address those is going to naturally provide benefit from a clinical perspective to our patients. So the advocacy that's necessary around better financial supports for primary care physicians, I would think needs to be paired with advocacy around those other providers of services that provide those social determinants as well. And I'll just make one other comment also about the technology, and we talked a lot before about telehealth. You can't do telehealth if you're not going to get paid to do it. And you can't get paid for something that there's not a CPT code for. So I just wanted to make sure that everyone is aware that we have been very fortunate in that the advocacy around the way in which you can actually bill for telehealth services has been successful, in the sense that there are now 17 new telehealth codes that are going to be part of the physician fee schedule for 2025. And that are going to be released in July. So perhaps being able to be paid to provide telehealth services will also be an incentive for people to use that technology to improve access to care.
And we should not underestimate the importance of convenience to our patient population. And telehealth really is a great enabler of convenient care. The number of patients that I've had even call my office and literally break out in tears and cry, telling me how much of their life they used to spend running from this location to this location to this location, and literally in tears say to me, thank God for your health center in bringing all those services in a coordinated and integrated way under one roof that makes my life easier.
I think you've really hit on a nerve with the money issue, because to me, the twin problems of relatively low reimbursement and coupling that with significant administrative burden is part of the big issue that has decimated the primary care workforce in this country. And the trainees see it. So there are significant disparities between income levels, between cognitive and primary care specialties with those procedural specialties. And it's millions of dollars of income that's forfeited over your career. And the trainees know it and they see it, and that's the thing that's keeping them away from these wonderful careers. So that's what has to be remedied. You saw that we invest so little of our $4.5 trillion healthcare spend in primary care, somewhere between 3 and 10%, depending on whether you look at it like a narrow definition of primary care versus a broader definition. But it's half of what our sister countries are investing that have much higher ratios of primary care patients, primary care physicians, and other clinicians to the population. So we have to get back to something like that.
And I'm hearing a theme from you all that sort of was planted as a seed in the last panel that we had as I was listening to them speak and thinking about why people choose to go into direct primary care, or why do they leave the model that they're in today. And one of the things that came up was this idea about, they didn't use the words moral injury, but I heard moral injury in the description, where you're asked to do a certain thing. So you decided you wanted to take care of patients because you wanted to take care of patients, and then you got put into a situation that was constantly blocking your ability to do that work. And it sounds like that theme is ringing true on our panel as well. And it makes me think about, you, Bill, and I know you said you're in a rural setting. I think you did too, Joyce, that you're practicing in these rural spaces. And I hear, similar to what we're talking about in primary care, students tell me, I love family medicine, Margot. I think it was the best rotation ever. I got to do all the things. I even really loved my rural family medicine spot. It was fabulous. I would never pick that as a place to go work. And you're like, wait, what? Like, you just said it was the best experience you ever had. Why would you not want to go work there? And they talk about their concerns about all the things they can't access and the things they can't get. Is that something that's just happening in family medicine, or are you seeing that in internal medicine or in pediatrics as well?
Well, I spent 5 years of my career in a federally qualified health center in a rural area. It was an amazing experience, a wonderful place to kind of cut your teeth as a physician, because there is so much that you have to do and learn on your own. I don't currently work in a rural area. I would say Charlottesville is not a rural area, though we are surrounded by a large rural population. But I think even for me, attracting new physicians to my practice is exceedingly challenging. And I think it's going to be even more challenging for any rural area. I think that, it takes a team. And even if you don't have like what's considered a classic, robust healthcare team, you need others to support you. More and more is being asked of primary care clinicians. And I think that those in rural areas feel even more untethered and harder to access support services. So I think they're going to be suffering from higher levels of burnout that make it just a harder ask to have them serve for extended periods of times in those areas.
Yeah, I don't have a lot to add to that, but I would say, though, that when we think about, we mentioned debt before and student loans, we do have some federally funded student loan repayment programs. And so the idea of incentivizing people to go and work in rural areas or other underserved areas using those programs, I think is tremendous. The question becomes, are we even investing in that enough? And I don't know the answer to that, and I don't know if you have seen that, and I would say probably not. But from a personal perspective, I never worked in a rural area. I did work in a suburban area. So moving from working in an urban area in a hospital setting where everything was right there that I needed, out to the suburbs, I felt like I was in an island. no, who am I going to call for this? What am I going to do? Where's the social worker? Those are the kinds of things that I think that people who train in a more academic setting as opposed to a community setting would feel those. So, I would argue from hearing the rest of our panelists here that those community-based training programs are really vital to being able to get people choosing to work in primary care, even if they love it. Then the question then becomes, well, what's the financial incentive to keep them there? So if you have the answer to that, that's great.
And that really is key. Exposing them and inducing people to work in a community-based setting is one thing. Being able to retain them is another. And the retention really turns first on adequate compensation. Because even when they come to us, and if they've taken advantage of loan repayment programs, they've got considerable debt that needs to be attended to. And their only means of satisfying that debt is adequate compensation.
I think that's true. In our clinic, we see medical students, PA students, nurse practitioner students that come through that we provide education. We try to really get them into community health, rural health, but most of them do not stay, and most of them say that it is reimbursement issues. My own son, one of them. So I think it's, it's a huge issue for primary care. They love it. They like the experience. Some of them are interested in how you figure things out without having somebody next door to ask what to do. So, those are all issues. I think it's good experiences to look more at maybe the art of what we do, but keeping them there. When I follow up with some of the students I've had, they're not staying in the rural areas, and they cite reimbursement.
Well, thank you so much. I get excited when I listen to you guys talk about sort of the idea that there are some really straightforward things to do. And I don't know that I could say this enough times for the people who are listening, but it sounds to me like money is a problem. And if we figured out ways to invest, and not just invest in the doctor's salary, because I think that most of the time people are saying that all you really want is more money and you make more money than everybody else. And I hear it as being much bigger than that. So what I'm hearing is an ask for an investment at multiple levels. So I've heard investing at the level of the community so that there are the resources to refer to when your patients are struggling with social determinant issues or health-related social needs. So I'm hearing investment in the community. I'm hearing investment in the practice so that the practice can have the supports they need. And then investment in the actual clinicians, because they did put in the work and the time, and they should be compensated at the same level as their colleagues. And how you get there is lots of different ways to do it, but that it sounds like it's a multi-level, multi-space way to do it. And in doing that, you might be able to create a workforce that's sustainable because they won't just be excited to come in, they'll be excited to stay. Is that fair?
Yes. And I would add investment to enable us to adopt the technology and really take maximal use of it. But it's not just in acquiring the technology, and we all learned that from deploying electronic health record system. It costs a lot of money to maintain an electronic health record system. So you can't just buy it and think it's done. There's an awful lot of maintenance that is required, and that costs.
Margot, first of all, I love the way you framed it. I think perfectly said. A lot of people may not realize that the physician fee schedule part of Medicare payment, that's the only part that's subject to budget neutrality rules. So all the other payments that go to hospitals, that go to hospital outpatient, inpatient, skilled nursing facilities, by statute, those funding levels go up as inflation rises. But because there has been no additional investment into the part that pays physicians payments have lagged behind inflation by 26%. Now, as you've said, this doesn't go to our own pockets. As a small practice owner, I want to make sure that my staff has a raise every year. The rent goes up every year. But if the payments don't keep pace with that, it makes it very difficult to do those things without giving yourself an actual pay cut every year. So this is why we're seeing a transition from independent practice to practices or physicians being employed. And about 30 years ago, 75% of physicians were at least part owners or owners of their practice, and now it's just the opposite. 75% are employed. And I once graphed out the trajectory of this to see when was independent practice going to completely end? Like when is the last dodo bird of primary care? And it actually turned out to be the year that I would hope to retire.
Well, I don't think the last panel is going to agree with you because they have a whole vision for how direct primary care is going to turn.
Well,
around.
that's the bad part. But these are the policies that have been put in place. So if we're talking about payment reform, the first thing I would say is, well, let's stop digging the hole that we're in, which is at least let's keep payments up with inflation. But it's way more than that because it means, as you said, investment in the community and really investment in new models of care, like evolving from the current fee-for-service hamster wheel that we're on into like models of per member per month, partially capitated or fully capitated models, pegged to the level of risk of the patient and their social determinants, and also leaning heavily onto team-based models of care.
I just want to add one more cost we've forgotten. That's the high cost of the barrier to entry into healthcare in the first place. The high costs of getting into school, going through school, dealing with the residency and preceptorship issues, that is a deterrent for many people to enter the healthcare profession today, no matter what path they choose. So there's got to be some real investigation into how to help with that problem. I know there are some solutions out there in the public health service and others, but they're not big enough. They're very small in comparison to the biggest debt load that we see our students come away with is in healthcare. So we've got to fix that problem if we're gonna, we heard the evidence is that there aren't enough people coming in while the pipeline is, bleeding out the other end, for lack of a better word. People don't want to go to medical school. They don't want to go to nursing school or anything else because they look at the cost of it and they say, it's not worth it. And then you tack onto that the primary care pay situation and they say, I'd rather go do something else. So we've got a real problem on our hands. We've got to start looking at this from the very beginning. The barriers to entry and getting kids who are 5 years old interested in becoming healthcare providers of the future.
Well, thank you so much for that. So we are cutting our time short because we could talk all day because I find y'all fascinating, but we'll get cut out. So we want to make sure that before we close out the panel, we have a moment to just think about if you had all the money in the world. So let's say Margot just convinced somebody to give us all the money and you were going to do one thing or invest in one thing. What's the thing that you would want to invest in? Why don't I start with you?
So for me, I would say to invest in pediatrics. Again, I think that, pediatrics is so unique, so different than adult care, and so the payment models for pediatrics really needs to be different than the models that many of you may be familiar with for adults. So I would say for me, what I would ask for is investments in pediatric services that do not rely on data and outcomes in the short term, but looking much more long term to the benefit of investing in children.
Oh, you're still thinking.
Oh, no. I'm not going to say just investment, larger investment in primary care, because I think many of the things that we spoke to today can be addressed by a more robust and significant investment in primary care.
Well, I was going to say the same thing, but I am going to say that I do agree with entry levels into the various health professions. If we want to have a more diverse workforce for nurse practitioners, PAs, and physicians, we really have to look at how we can bring all of our population, some of our most vulnerable, into the health care education system and keep them there.
And I'll say, invest more total valuation in primary care and cognitive care, evolve to new models of care, and I'm going to keep hammering away at the administrative burden that needs to be reduced.
And I would say we're investing for the future, meaning that what I said just a few minutes ago, we've got to invest in the children of today to bring them forward into this healthcare system so that we have more providers to care for the rising population. So investment in the beginning of the pipeline is what I would say. I do agree payment reform has to be given to providers today, but if we don't have anybody to pay in 10 years, what are we going to do? So we got to start at the beginning.